right? Which is a combination of a speculum exam and acquiring a sample in order to look for a particular disease known as cervical cancer, right? So a pap smear is really preferred for all types of women at least 3 times in your life, by your 30s, your 40s, and your 50s. But if you do have comorbidities that link you with an immunodepressed system, you are required to do more pap smears in order just to monitor, if any, progression of cervical cancer. So I'll be taking you guys through a very sterile step-by-step procedure. I'll try my best to show you and explain to you what we do step by step. So I hope you guys enjoy. Thank you. You've acquired consent from your patient and you've made them aware of the procedure. You ask them to get into the lithotomy position. This just needs your knees to be flexed and the ankles to be close to the buttocks, right? So when you're with your patient, you only expose below the waist. That's the area that we're dealing with. Then you grab a speculum. So there's various types. This is a metal speculum, but there is also a plastic one, which is disposable. Advise not to always use lubricant, but if the situation permits, then you can. Just don't use it at the tip of the speculum, because that's where you'll be acquiring your sample. So once you've gathered all your equipment, you inform the patient that you're about to insert the speculum. So you make sure that your lighting is perfect, and you make sure that you close the speculum and turn it towards the side, right? So you try and open up the vaginal opening of your patient, slide the speculum in. As you slide it in, you twist it to face the right way up, right? Then you'd have to open the jaws slowly in order to visualize your cervix. Once you visualize your cervix, then you'll be able to lock. So you turn the screw and you lock your speculum so it doesn't move or it doesn't unclamp on its own. So you've got a very stable workspace. Speculum is secure. You grab your spatula, where you'll use both ends of the spatula to acquire a sample, and you make sure that the spatula does not touch anything else but the cervix that you need it to, so that your sample is clean. Then you'd get a cervical brush and you make sure that it goes directly to the cervix and directly out. With the cervical brush, you rotate it 360 degrees for about 5 times clockwise in order to gain the most amount of sample. You remove it, and then you get the sterile water cup that comes with it specifically for those cells. You insert it, you break the handle off, and you close the sample immediately. You've acquired all the necessary specimens. It's time to remove the speculum. So you unhinge it, close the jaws, you rotate it to the side, open the vaginal canal, and slowly retract it. You dispose of the speculum, you thank the patient, and you cover them. The next video we'll be looking at is called a intercostal chest drain or chest drain, right? Simple terms, it's us putting a tube inside your chest. Now there's reasons why we do this. We could do this if you have a collapsed lung most of the time, and we typically do it if there's a combination of fluid or blood or pus and air in your lung cavity, right? We don't usually do it when it's just air. There's another procedure that we can work towards that. But in this particular case, if we do notice that your life is being threatened, it's very difficult for you to breathe, and your lung is collapsing by the minute, and even your heart and the other lung is being pushed and compressed further, it is very vital that we do a chest drain for you. So I'll be providing you guys with somewhat of a step-by-step procedure. There are steps that will not be done physically, but I will be able to narrate them. So I hope you guys enjoy it. Thank you so much. So when you do an ICD, you need to have your equipment on standby right next to you so you don't have to run around looking for things, right? It's important that you get the patient in the right position, and this is a very sterile procedure, so sterile gloves are very key. The best position would be asking your patient to sit upright and elevating their arm up. If they can't elevate it themselves for a long period of time, you can restrain them so that the arm is left immobile, so you've got full access to the armpit region. Right. So the area in which we're going to put the tube is very important. We work on the 4th intercostal space at the mid-axillary line, right? We're looking at the safe triangle, so anywhere between the 4th, the 5th, or the 6th intercostal space. Once you've located the area, you have to put local anesthesia. So we use lidocaine 1%, no adrenaline, or adrenaline if you do have it. And we make a skin wheel just so that we anesthetize in layers so the patient doesn't feel pain gradually. Once you found the area, you make a small incision with your blade And with your finger, you blunt dissect as I was doing in front of you. Then once you've located the pleural space and you've made somewhat of a, hole in the pleural space, you're able to get your tube and clamp a needle holder to the tube. So as you're advancing, you're trying to go back to the hole or the space that you made with your finger, right? And the moment you're in, there should be backflow of blood or air, a gush of air, or any type of contents that are in the cavity that is obstructing the patient from breathing, right? It's very important that you get as much of the tube in as possible, and how you angle it is very important. If there's air accumulation, you angle it up, and if there's fluid accumulation, you angle it downwards to collect all the fluid. Then we'd have to secure the ICD, right? It's very important, otherwise it will come out. So we use a very big needle. Very important because the thread of the needle is quite thick and tough. In this case, I was using silk size 1. And there's various techniques of securing an ICD. I use a Sowetan method, or Joburg method as it's known. So you kind of make a U shape with your thread, and you will have to be using either a needle method to suture, or you can actually use your fingers to suture. I prefer using my fingers because it's more hands-on, and I've taught myself the technique, so it's quite natural to me. But you're more than welcome to use a needle holder method as well. So the important part here is that you have to cut off the needle from the suture, otherwise it will hurt you and subsequently your patient. And this is where we do the finger technique, right? You make sure you secure and you do multiple knots, multiple layers, as long as your ICD doesn't move. That's the main goal here. And as long as anything surrounding the ICD, the laceration that you made with the blade, is covered. You don't want any contents leaking out from the chest or leaking into the chest, causing further complications to your patient. During the video, I did connect the open water seal with the ICD tube so that it's easier for me to actually detect when there is backflow and if the tube has correctly been inserted into the chest. That way I'd be able to see if there were any air bubbles or bubbling of the open seal, and then it would confirm that I'm in the right place. Once you have confirmed that your ICD has been set in place, it is procedure to do a post ICD chest x-ray to confirm that you've not compromised any other organs. And it is also advised for your patient to use a glove and blow into the glove. This helps expand the lung capacity, specifically the affected lung that was caused to deflate secondary to the accumulation of air or fluid that is not supposed to be in the cavity itself. So by blowing into the balloon or the glove in our case, it helps the lungs to just re-expand into its natural form or its natural physiology.